Muscle Doctor, hi, it's Liam here, and today we're going to take a look at the anatomy of the core. Now first, how do we define the core? Is it the abdominals? Is it the core of the apple, so the deep muscles of the spine? Or is it everything between the rib cage and the pelvis? Well, hopefully, as you'll come to find out today, it's a combination of all of those things. So let's take a deep dive into the core, beginning with the outer layer. And we're looking anteriorly. We've got the external obliques. So we've got external obliques, we've probably got internal obliques, and they would be just inside. So both of these muscles serve to rotate the vertebral column. And then we go a layer down into the third of four layers of the abdominals, and we've got rectus abdominis. So we're still on the outer layer at this point. Obliques and rectus abdominis. Rectus abdominis, they're the six-pack abs. They're the things that we think of when we think abdominals. But we'd have got two layers of obliques over the top of them. Rectus abdominis originates at the pubic crest, pubic symphysis, and inserts xiphoid process and cartilage of ribs 5, 6, and 7. It's on the front, it brings insertion closer to origin, so it's going to flex the vertebral column. We probably all know that. We've all done a crunch, or at least attempted one in the past. So still on the outer unit, and we're coming around posteriorly, we've got the erector spinae. So the erector spinae is the big muscle group at the back of the body. Posterior to the spine, it extends the spine. And we can break it up into three groups, and then we can break it up even more. So we've got the iliocostalis, first of all. Clue is in the name, attaches the ilium to the costals, or the ribs. And then we've got longissimus. And we've got the different sections of longissimus as well. So longissimus thoracis, longissimus cervicis would be up near the cervical spine. And then most medial, we've got the spinalis. So the three together, iliocostalis, longissimus, and spinalis. So one mnemonic for memorizing these is I long for spinach. I long for spinach. Another way is the three Mexicans, iliocostalis, thoracis, spinalis. I can't do it to myself. But you pronounce them in a Mexican way, and it sounds like the three Mexicans or the three amigos, it's often called. So this is the outer unit, and we've also got the fascial slings, which we'll get into in another video. Notice that the abdominals are kind of broken down into those different layers. We don't think of the core as abdominals in this case. So that's the outer unit done. We're going to get into the inner unit now. So the second of three layers or three units. And here we start to paint the picture of a drum. So this is how we kind of maintain our intra-abdominal pressure, which helps to bolster the spine and strengthen and support the bony structures of the vertebra. They say that an unsupported spine can manage about 4 or 5 kilos before collapsing. And since your head probably weighs about that, it goes to show the amount we rely on the muscular tension around the spine to give us that support that we need. So the first layer that we're looking at here is the transverse abdominis, often abbreviated to TVA. You may have heard it called that before. This is the corset of the body, and it wraps all the way around posteriorly. So if you are some kind of manual therapist and you treat the back and you think the QL's in there, don't forget about the TVA as well, because it is in there. TVA, so that would be the outer skin of the drum. And now we need to look at the top and the bottom of that drum. So we take the TVA off, and we've got the diaphragm. So diaphragm, most people know about that as a muscle of inhalation, and that's its primary action, is inhalation. But it does form a very important part of the core. And it's the relationship between this transverse abdominis and the pelvic floor that gives us the intra-abdominal pressure we need to support the spine. So you can see now how all these different layers are starting to come into their own as far as importance goes and significance for supporting and stabilizing the spine. The diaphragm's primary action is inhalation. We've got lots of accessory inhalation muscles as well. These are usually muscles that connect to the rib cage. So serratus, posterior, superior, and inferior. The scalenes, serratus anterior, pec major, pec minor, lots and lots of different muscles. Why am I mentioning these accessory breathing muscles? Well, if the diaphragm is not working functionally and properly, we're not able to contract it, these other muscles potentially could be chipping in and doing too much work, more work than they were designed to do. So we have a problem there, a twofold problem, where the diaphragm, much like any other muscle, if it's not used correctly and adequately, it will atrophy. So it will shrink, it will weaken, we become less able to use it. So these other accessory muscles, the muscles that people often come into clinic with pain, they get overused and overworked. So not only are we unable to generate the intra-abdominal pressure through recruitment of the diaphragm, but also these other muscles around the neck, shoulders, ribcage get overused and can become tight and painful. So that's the diaphragm, and you can see it's got big origins, big insertions, and then, well, the insertion really is one central tendon, which is into the middle. It's a very unique muscle in that way. So that makes the top of the drum. Then we look at the bottom of the drum, and we've got the pelvic floor, which, prepare for quite an unflattering view. Apologies, essential anatomy skeleton man. We have got a lot of different muscles in the pelvic floor, some that I won't even attempt to pronounce. The two, for whatever reason, that we focus on when it comes to anatomy, at least in the soft tissue therapy world, are levator ani and coccygeus, which is in there somewhere. So iliococcygeus. You could write a whole thesis. You could do a PhD, and there have been many, many books written on the muscles of the pelvic floor. Just know that they contain the visceral contents, so they provide a floor, as would be indicated by the name, to the abdominal contents. And we need this working in conjunction with the diaphragm and transverse abdominis to be able to give us the intra-abdominal pressure that we need. So there's one more part to that inner unit, and it's a big one. It's the core. It's not going to be simple. So we've got the Mrs. group, MRS. We're going to have to strip down some layers for this. So we've got the multifidus, or multifidi here because it's plural. Multifidus is going to be the only muscle that's palpable on the posterior sacrum. So just remember that. You can have a feel now there. You can forget about these muscles with them being quite deep often, but it is palpable, at least in that portion. And this, as you can see, is quite an extensive muscle. It kind of has an oblique fiber direction where it connects a spinous process of one vertebrae to the transverse process of the vertebrae 2 or 3 below. I mention that because rotatores are the R in the Mrs. group, and they have a very similar formation, just on slightly fewer layers. So they go from the transverse process of a vertebrae to the spinous process of the one above it. So both of those muscles, multifidus and rotatores, rotate the spine. And these muscles become very important as we're getting down to that, closer to the core of the apple kind of core, the deep muscles of the spine. We can start to visualize how tension in these muscles is important to be able to bolster the spine and give it some support and some muscular tension. If we think about common spinal injuries, so things like disc degeneration, bulging disc, herniated prolapse discs and things like that, we are often told that we need to strengthen our core. These muscles are often forgotten about, and these are ones that are important to think about when you are strengthening your core as a result of an injury such as that. And you can see why. They're the scaffolding of the spine. If we've got adequate tension in these muscles, it's going to be offloading those discs to some degree, and it's going to be strengthening the spine from the very deepest layers. I haven't forgotten the S. We've got Mrs. group, MRS, multifidi, rotatores, and then we've got semispinalis as well. So semispinalis, that's not it. That's not it. There it is. I don't know why it's divided up into these layers, and you will see it divided up into these units in different ways in different textbooks. This is just the way that I subscribe to, and it's the way that I've seen it that makes the most sense. Outer unit, inner unit, and deep unit. But there we've got the semispinalis cervicis. Just like with the erector spinae, certain muscles will be divided up again into the segment of the spine that they act on. So we've got cervicis, thoracis for thoracic spine, and lumborum for the lumbar spine for certain muscle groups, mainly the erector spinae. So that's the Mrs. group. So that's the 4 layers of the inner unit. We've got transverse abdominis, we've got the diaphragm, and we've got the pelvic floor, which is now missing. We've got the Mrs. group on the back. So that's kind of the zip at the back that keeps everything all together. So now we get to the deepest layer, or the deep unit. We're going to have to remove some muscles for that. So in here, we've got a few muscles that are often not talked about. We've got levatores costarum. So these elevate the ribs. They're a muscle of inhalation. and exhalation to some degree, but they are in there and they constitute one of the muscles of the deep core. How much do we need to know about these muscles? Not a great deal as far as I'm concerned. We can't see them, we can't touch them. We need to know that they're there and roughly what they do. But if I was to ask you to contract your levator costarum, could you? There are certain muscles, exercises that we can use to contract these muscles to know that they're working based on their action, which we'll talk about in a moment. Two other muscles on this deep unit. We've got intertransversarii. Say it with me 3 times fast. Intertransversarii. The clue's in the name. They are the muscles that connect the transverse processes of the lumbar spine, at least. And then we've got interspinalis. I'm going to have to zoom to get to that. There they are. Tiny little muscles. Interspinalis, so they connect the spinous processes of the spine. So can you see that every bony projection, every bony prominence that we've got, there's a muscle to connect one to the other. So much like ligaments in the rest of the body, but here we've got contractile muscles. And they are contractile. They can be used and they can be recruited, and they're often not. So let's have a guess at what these muscles do. We've got the interspinalis muscles. They're on the back. They contract. They're going to bring one spinous process closer to another. So spinal extension. Intertransversarii, again, they're going to bring one insertion closer to the origin, and that's going to laterally flex the spine. So just to summarize there, the 3 layers before we move on, we've got the outer unit. So we've got the abdominals in external oblique, internal oblique, and rectus abdominis. We've got the erector spinae as part of that group as well, which are the iliocostalis, longissimus, and spinalis muscles. We've also got the fascial slings in that layer as well. Strip that layer off onto the inner unit, and we've got the drum. We've got the outer skin of the drum, which is the TVA or transverse abdominis. We've got the top of the drum, which is the diaphragm, and the bottom of the drum, which is the pelvic floor. We've also got the zip at the back that keeps everything together in the misses group. So multifidus, rotatories, and semispinalis. We take that layer off, and now we're into the core of the apple. So we've got the interspinalis, intertransversarii, and levatoris costarum. There are a couple of other muscles that we need to think about when it comes to the core. These don't necessarily have a unit of their own, but they're in there and they're significant. And they're actually some of the muscles that we can palpate and that we can more obviously see and feel. We've got quadratus lumborum, which connects the iliac crest to the last rib. And it's got a strong insertion on the transverse processes of the lumbar spine. So that, when seen in this view, sits right on the back, so posteriorly to psoas major. And this is a muscle not to be overlooked when it comes to the core and back pain in general, I think. This is a big muscle, often known for flexing the hip, but look at the size of that origin on the lumbar spine. So a big, thick origin, it's kind of hugging those lumbar vertebrae, really, bodies of the vertebrae as well as transverse processes. And really, it would be a posterior muscle if everything else here wasn't in the way. We do get to it with some manual therapy techniques anteriorly and slightly laterally, but don't forget about it. This is kind of like a rotator cuff for your lumbar spine, if that could be such a thing. It's heavily involved in core stability. If this muscle is dysfunctional or weak, it's not going to be giving us that strong support of the lumbar spine that we need to remain pain-free. So the last thing that I'm going to say here is about some of these very, very deep muscles. I mentioned earlier on about being able to recruit them and contract them, but also said jokingly, can you contract your intertransversarii? Probably not, or if you can, well done. But how would you know? You can't, because we can't palpate that deep. My tried and tested approach for utilizing these muscles, and you will be activating other muscles, sure, of course, the body doesn't work in isolation. It's one unit that works together. We're going to use isometrics. Why do we use isometrics? We use isometrics because if somebody comes in with back pain and they're getting pain on lateral flexion, or extension, then maybe we don't want them to be doing those movements just yet. But we can still activate the muscles, giving us a couple of things. So we can have exercise-induced analgesia, which is pain relief, a natural pain relief from movement. which is obviously favourable to any kind of exogenous pain relief. This is going to activate those muscles without doing the movement that causes the pain. And we can use this with any movement of the spine: lateral flexion, rotation, flexion, and extension. And these are the muscles that we're targeting. The way that I'll explain this often to clients in clinic is that these muscles are the scaffolding of the spine, and we need adequate tension in them to bolster and support the spine. So that's the core. I hope you found that helpful and it was clear enough. It's quite a cloudy subject at times. Please like and subscribe and comment. And if there are any particular anatomy videos you would like to see, I'd love to hear from you and I would be happy to make one. Bye for now.